Okay, you guys can, I'm sorry I had to interrupt my lecture and turn this into 2 parts. I had that phone call and then I didn't have enough time to finish when I got done. So let's get this part finished and we will move on. So it should be here at chemical factors, I believe, and then we are on page 313. We talked about neural factors already. All right, so chemical factors, see where it says chemoreceptors? Chemo, always think chemical. Okay, so they receive chemicals, or that's what they're looking at. That's what those receptors are measuring. So we have central chemoreceptors, peripheral chemoreceptors, and then mechanoreceptors, which is, think mechano, think machine, okay, like a mechanic, right? All right, so let's look at 313, chemical factors. It says most people don't think of oxygen and carbon dioxide as chemicals. When it comes to respiration, that's how they're classified. Okay, so they influence the inspiratory and expiratory centers of the brain because our brain says, hey, we need more oxygen or we need less oxygen. What do we need? I'll raise this up so you guys can actually see me. It says because oxygen is essential for maintaining life, you might think it exerts greater control over the rate and depth of breathing than carbon dioxide. However, you'll see that there's several things. So carbon dioxide plays a role and oxygen. Our body's constantly reading what's going on and saying, breathe more, breathe deeper, breathe, slow down your breathing or speed up your breathing. And there's just, that's part of homeostasis, just like we've talked about with all that feedback, same idea. All right, so let's look at central chemoreceptors. Okay, so these are specifically in the brain. It says within the respiratory centers of the brain are sensory cells called central chemoreceptors. These constantly monitor changes in cerebrospinal fluid, pH, and then a decrease in the pH says that there's too much carbon dioxide in the body. So that's what our brain is measuring. Cerebrospinal fluid, remember, is that fluid. It's like a clear, watery kind of fluid that is what the brain, it cushions the brain. It helps to nourish the brain. It's all the way around the spinal cord. So our brain is constantly monitoring the pH of that fluid. And when the pH changes, says a decrease in the pH. So when the pH goes down or it gets more acidic, right, then it's saying that we have too much carbon dioxide. As when metabolism increases, oxygen consumption accelerates and the body produces more carbon dioxide. Okay, so the more oxygen our body uses, the more carbon dioxide it's going to produce. It says in excessive quantities, carbon dioxide can be dangerous because it's the only chemical that can cross the blood-brain barrier. Remember we was talking about the blood-brain barrier in the nervous system? So we have a lot of drugs cannot get through, and some things can and some can't. And carbon dioxide is one that can. High levels increase the number of hydrogen ions in the body. These hydrogen ions cause the pH of the cerebrospinal fluid to decrease. When this happens, then they stimulate the brain's inspiratory center. So they send impulses to the inspiratory center via the vagus and glossopharyngeal nerves. Those are some of the facial nerves, cranial nerves. And when it gets this information, it stimulates the rate and depth of breathing. So the rate means it stimulates the number of breaths per minute. So normal adult breathes 12 to 20 times a minute, somewhere in there. And that's the norm. In and out is 1 breath. There's 1. That's 2. Right? So our brain is going to say, hey, we've got too much carbon dioxide going on. We don't have enough oxygen. We need to increase the rate. So that's increase the number of breaths per minute and the depth. Okay? Think about when you're just sitting hanging out or you're really tired, you don't breathe very deep, you go, chest kind of goes up and down. But when you're running or something like that, you're breathing really deep. You're trying to get more oxygen. So same idea there. So it says, as you can see, carbon dioxide is the chemical driving force behind respiration. So we'll look at this picture in just a second after we talk about these other two. All right, peripheral chemoreceptors are in the aorta, which is the largest artery in the body. That's the artery that comes off of the heart that feeds blood to everywhere else in the body. And then the carotid arteries are the arteries in your neck. That's where you feel your pulse, right? In your neck, that's your carotid pulse. And that actually brings blood to your brain. So two very important arteries. It says they're mildly sensitive to carbon dioxide, but in pH, but less so than they are to oxygen. Those two in particular are very sensitive to oxygen. So they say, okay, we've got enough oxygen, we're good to go, or we don't have enough oxygen, we need to increase the rate of death. So then they do the same thing. They send messages to the brain, and then the brain decides, hey, we need to speed up breathing, or we need to breathe deeper, or maybe we need to slow it down, whatever we need to do. And then the last thing that plays a role in the control of our breathing is our mechanoreceptors. These are located in muscles and joints, and they detect muscle contraction and force during exercise. So it says they're responsible for a quick increase in ventilation. So when you first start to exercise and you kind of get out of breath, right, that's what those are responsible for. So it sees, okay, our muscles are working really hard, which means they're going to need more energy and they're going to need more oxygen. So we need to increase our depth and rate of breathing. So those are three ways that our breathing is controlled. We already talked about the medulla oblongata and the pons. Okay. All right. Let's look at this real quick. This picture's in your book too. It's kind of just a little, picture about what we just talked about. So if you look over here, so stimulus is inspiration. It says chemoreceptors in the brain send messages to the inspiratory center. Same thing, and this is the aorta. So it's measuring out oxygen, a little bit of carbon dioxide and pH, picks that up too, but mostly oxygen. And then the muscles are saying, hey, we're using up energy, we're using up oxygen, you need to breathe in more. So goes over here, okay, to the inspiratory center in the brain. That's the medulla oblongata and the pons. They work together. Remember, the medulla oblongata is your quarterback. Okay, it kind of sets the pace. And then your pons is what coordinates your breathing. All right, so then we have a message that goes to your muscles, to your external intercostal muscles and the diaphragm. It says, hey, contract. We need to start breathing fast. Then we expire, right? We breathe out. And then response is, again, stimulus is expiration or response. So it's all going to go back. It just constantly, it's like homeostasis, right? It just feeds in and feeds out. We get feedback, we speed up our breathing. We get feedback, we turn it down, whatever we need to do. All right, lung volume. So now we kind of see how the lungs are regulated. And one thing I want to tell you guys that wasn't really, I really don't talk about in here, but the way that our lungs actually open up, okay, we talked about the two layers of tissue, right? The parietal pleura and the visceral pleura. Okay, and I think I said this to some of you guys, but the parietal pleura, okay, sits on is like the lining that's on the inside of your chest cavity. Okay, so if you were to open up your chest, you open it up, the parietal pleura is actually going to be on the inside of the ribs. Okay, the visceral pleura is actually the lining that's directly on the lungs, on the outside of the lungs. But these two together make up our pleura. They're the lining of our lungs. It's double layered, right? So you got two layers, the visceral pleura and the parietal pleura. And what happens is that parietal pleura is actually, it clings to the top of the diaphragm and the inside of the rib cage. So when the diaphragm contracts, right, and the rib cage moves out because of those external intercostal muscles, then that parietal pleura moves out with it because that's its cavity. That's what it is. It lines all those areas. Well, because there's pleural fluid in between that lining of those two, there's actually suction that works between the lining. So as those open up, that visceral pleura clings to the parietal pleura on the outside, and it pulls on the lungs and basically opens them up, right? Forces air into the lungs because it's pulling, if you will, it's pulling, like sucking air into the lungs. So some of you guys have heard about somebody having like a collapsed lung. What happens in a collapsed lung, or well, this is one thing. It's called a pneumothorax. But if that double layered membrane is punctured, okay, or injured in some way, then it can separate. And it's kind of like it really does, if you get stabbed or gunshot wound or something, it can make like a sucking chest wound. I mean, it literally, because of that pressure that's inside, and it breaks. It's kind of like if you put a suction, like a toy or something, and you suction it to the bathroom wall. You know, it doesn't do very good when it's dry, but when it's wet, you can put it on there and it will stay. And then once you peel it off, one little part doesn't come off, the whole thing comes off, right? You can't just, make half of it stick because it sticks by suction. It's the same idea with these two linings. So if you break that seal, the lung, okay, is going to shrivel up in its place. And that's really a collapsed lung. The pneumothorax, it's got air in that lining, which is not where it's supposed to be. We'll probably talk about that with 9.32, but anyways, just a side note. All right, so let's look at lung volume. And we're going to do a lab on this Friday. So you'll be able to see tomorrow. Yeah, this one. You'll be able to see a little bit more of this. So static versus dynamic. Let's look at this on 315. A few things to note about lung volume. Okay, so we're talking specifically about how much air can fit into the lungs. Obviously, that's going to change with age. Okay, infants are born, their chests are like this big, so their lungs are that big. They can't fit as much air in their lungs as you can. Makes sense. Okay, static lung volume, the difference between these two is static lung volume measures only volume. Dynamic lung volume measures volume based upon a time frame. So it says, for instance, a dynamic lung volume measurement might assess the ability of the lungs to forcibly expire air in 1 second. So it puts a time limit on it. Static is measured by a spirometer. It says dynamic is measured by using a flow volume meter. We're going to use a spirometer, I believe. I haven't looked at it lately. I have both. So anyway, static lung volume. So these are, turn over, and I'm going to give you guys a cheat sheet, and actually you can have a copy of it. There's a copy in the notebook for you guys to have. All right, turn this back down though. All right, so these really help when you're testing for disease or different kinds of lung problems. You look at all these different volumes, and if they're really getting a volume that they're supposed to get, or if they're not, like can kind of see what's going on from there. All right, so tidal volume. This is like your normal breath. This is the amount of air in a normal breath. To measure this, measures of static lung volume are important. We already read that. First, the person is instructed to breathe normally for at least 6 breaths, and then they'll figure out their tidal volume. That's just your normal, you're sitting, just your normal breath, okay? It's the amount of air inhaled during a normal breath. Mine's probably a little less than normal right now because this baby's in the way of my lungs, but makes me out of breath really fast. Followed by a maximal expiration. Okay, so just a normal breath and then maximum expiration. So that's how you figure out tidal volume. vital capacity, okay, this is the total amount of air that can be forcibly expired after a maximum inspiration. Okay, so this means you breathe in as much as you can. Y'all do this with me because I'm going to get out of breath. And then you breathe out until you can't breathe out anymore. Made me cough. So that's vital capacity. Okay, you breathe in maximum amount, you breathe out maximum amount. And so when we say forcibly expire, remember I told you guys the other day that expiration is really a passive process, right? It's not something that you have to force all the time. You can force it, but you don't have to. So if you're looking at this, okay, this is telling you your vital capacity is virtually like as much air movement as you can get out of your lungs. So you breathe in the maximum amount and breathe out the maximum amount. That's what this graph is telling you. Okay? Residual volume is what is left in your lungs after you forcibly expire. So after you just did that, you breathed in the maximum amount and you breathed out the maximum amount, there's still going to be some air in your lungs. That's called the residual volume. Even though you pushed all of it out, you still have that residual volume in your lungs. That's what that one is. Functional residual capacity. Looking for it on here. I'm not even seeing it. Functional residual capacity. This is the amount left after a normal expiration. Okay? Functional residual capacity. The amount of air that remains in the lungs after normal expiration. So you take your expiratory reserve volume and your residual volume, add those two together. This right here, this yellow and green together, this is what's going to make your residual volume. Okay? What did I say? I'm sorry, that was your functional residual capacity. I said that wrong. The inspiratory reserve volume, okay, is the amount that can be inhaled after a normal exhalation. Inspiratory reserve volume, the amount of air that can be inhaled immediately after a normal inspiration. Okay, so you breathe in, and then you force yourself to breathe in more. Okay, the difference between the most you can breathe in and then your normal amount of breathing in, that gives you your inspiratory reserve volume. And think about the words in here that make sense. Reserves are like extras, right? Your tidal volume is just your normal breathing volume, right? Your vital capacity, vital is like what it takes to live, right? And you can take in as much air and out as much air, and that's your vital capacity. Residual volume is like what resides, right? What's left. So think through these names. They're going to make sense to you. Okay. Expiratory reserve volume is how much you can breathe out after a normal expiration. So I breathe out, and then you breathe way out. Right? You force as much air out as you can. And then total lung capacity is virtually everything goes from your residual volume that you really can't access all the way up. It's basically your vital capacity plus your residual volume, right? It's everything that you can breathe in and breathe out plus the air that's left. That's your total lung capacity. It says usually measures about 6 liters of air. So those are your lung volumes. We're going to look at those again, like I said, Friday in the lab. So we will be doing that. These are all static lung. This picture right here is on 316. I'm sorry. All right, your dynamic lung volume. So this one takes special equipment. I don't think we'll be able to do this. We have some spirometers, but they probably don't, or flow meters, but they're a little bit different than what this is measuring. There we have like some asthma flow meters and things in there. But so it's a measurement of a flow rate during a forced vital capacity maneuver. Flow rate during a forced vital capacity maneuver. It says pulmonary function testing by a computerized flow volume meter is used to measure dynamic lung volume. They're called PFTs, pulmonary function test, PFT. So, but they're looking over a time period usually. They use these to diagnose asthma, chronic obstructive pulmonary disorder, and several things. So look, forced expiratory volume in 1 second or 1 second in forced vital capacity. So those are the two. They're in the middle of page 316. So that's what you added in there is time. It says people with restrictive lung diseases such as cystic fibrosis or pneumonia have an increased stiffness in the lungs, which prevents them from expanding normally. Lung stiffness causes static and dynamic lung volume values to be much lower than normal. So we'll look at more. But yeah, you think about if it can't expand like it needs to, they're not going to hold as much oxygen. That makes sense. Okay, but that's that on 9.2. I told you guys this chapter is short and sweet. So we will finish up some of that on Tuesday next week. Tomorrow you guys have a lab. Make sure you read over your lab before you get to class. I think that's it.